session for educational purposes, so please make sure you mute your phones and pagers just to try to minimize disruptions. We do offer CME and CEUs. They're provided for this event. So please look at your email, or you can go to the ANTHC Palliative Care ECHO website for details. Well, we're really excited to have Dr. Sean Tempain as our guest didactic speaker. Sean is our ANTHC Palliative Care physician. He's going to be presenting today on care during the last hours of life. So just know that if you have any questions about today's didactic, we're going to have an opportunity at the end to ask some questions. So just jot them down, and we'll make sure that we reach out to you to see if you have comments or questions. So I'm going to turn things over to Sean. So again, thank you so much for being here.
Sure. I think this is a really important topic, and I'm excited to be presenting on it today. My hope is to get through some of the material in order to have a little bit of discussion, since this is a point I think people are universally curious and anxious about. It's a universal experience. And in palliative care, we talk a lot about care during transitions and sometimes care during the last phase of life. This is truly care at the end of life. And so we'll get started. Next slide. So first, a quote from Joan Halifax. We live in a time when science is validating what humans have known throughout the ages, that compassion is not a luxury. It is a necessity for our well-being, resilience, and survival. This is from Joan Halifax, who is both a Buddhist and a longtime hospice pioneer. She has wonderful work on being with people in the dying phase of their life and what growth can come of that, what meaning, and teaches compassion not only for the patient but for ourselves. And that's what I want to stress today as we go through some of the principles and some of the recommendations. It's really about being humble, providing compassion and presence, and a lot of things will sort themselves out. There's certainly best practices, but we want to have courage and be present with these patients. So a few objectives. The first is to recognize as well as we can that someone is actually dying. I think that's actually really challenging to do. There isn't quite a typical death. There's certainly some signs and there's certainly experience that guides us, but that's something we should all push ourselves to do, is ask the question when we see people, oh, are they actually moving into the dying phase of their life? So it's very important. The second is to review both medications and other strategies to alleviate the various forms of suffering that are common in the last hours of life. And then recognize opportunities to educate and support both patients, families, friends, as well as other healthcare staff who may be less experienced or looking for guidance and reassurance. So the first step is recognizing that someone might be dying. You know, this includes several phases, sort of the early transitions. And this is not, you know, again, nothing is typical. So someone could progress through these stages all within 24 to 48 hours, depending on the medical process that's occurring. But for a lot of our patients who have multiple diseases or cancer or have a more predictable course, we start to see these changes over time. Within the last few weeks of life. And so you can see early on, definitely a decrease in functional status, less moving around, taking in a little less food, starting to change the way they think a little bit. Kind of in that middle phase, we really are getting closer to the end of life. The patient might be confused, or they may be minimally interactive, sleeping a lot, and starting to have some difficulty with secretions. And then truly at the end of life, the patient may be totally unresponsive or minimally responsive, definitely with breathing changes, decreased perfusion and modeling, and decreased hearing output. So let's say you decide that a patient is dying. It sounds funny to say this, but this happens in the hospital sometimes, and I wonder if it happens in the community as well. People are afraid to make that statement. They're afraid to be wrong. As I mentioned before, it is so difficult to actually be sure. But it's better to tell them than to not, because patients and families have an opportunity when they know this is occurring to do very important things and to not be surprised by something that can be fairly traumatic. So the first step is to tell the patient and family. And if you're not sure, tell them you're not sure. But go ahead and tell them that you think this might be occurring. The next is to confirm the goals of care. So those may be clear. We may be in a situation where the family has decided to be on what we call comfort care, where everything is directed at making the patient comfortable. But it's good to revisit these and explore that based on these goals of care, these would be my recommendations about how we address the patient during this last phase. Talk specifically about things you might consider, things that certain families might choose or not choose, and based on those goals and your understanding of the family, you're going to talk about how this could be helpful or not. For example, in the hospital, we often talk about, okay, we think this patient's dying. It might be best to disconnect them from the monitors. This can be less stressful, allow us to focus on the patient in front of us and how comfortable they are. It can be very distracting. It could give us anxiety to just stare at the heart rate and wonder, when's it going to stop? These are recommendations you might provide. However, some families feel that it's very helpful to keep the monitor on. And in that circumstance, if you've discussed what the benefits and burdens can be, you certainly can accept and support that type of decision. And then do your best to set expectations. Best guess of timing. People often want to know, like, how soon is this going to be? Many families and friends choose to kind of hold vigil over the patient. And if you think it's going to be weeks, that can be a pretty fatiguing and exhausting time period. If you think it's going to be shorter, let them know so that if they say they're going to go take a break, well, I'm concerned that if you do take a break, that this could happen in the next hour or two. And that's really helpful information for people who want to be there at the moment of death. Next slide. So again, our talk today is mostly focused on this middle to late phase, given that a lot in that early phase can happen at any phase of serious illness, but really going to be focusing on the middle to late phases, very close to death. So in thinking about how best to care for a patient and their family, really our goal is the same as it's always been in palliative care. We're always looking to promote patient dignity and improve their quality of life. Just because they're very close to death doesn't mean there's not opportunities to work on quality of life, on figuring out what's important to them, on elevating things you know about them and their sense of self during this very last and important phase. We talk a lot about good deaths. I'm a little bit concerned because that often comes from medical professionals thinking of what a good death can and should be based on our experience. But I really think the best possible death, because nobody wants to die, is defined by the patient and family and what's important to them. And it's a little bit different in that we may be at a loss to know what is good or best for a family in this circumstance. And we really tend to rely on them while bringing our own expertise to play when asked for. We do this often by addressing different sources of suffering. Again, in palliative care, we really have that holistic model. We address spiritual needs. We look for sources of psychological distress, social distress, really looking at the broader family. We talked about the patient may or may not be interactive, so a lot of our work is going to be with the family. And then sources of physical suffering, because if there's perceived physical suffering, it becomes very challenging to address all of the social, psychological, and spiritual needs. So that becomes a high priority in order to be able to address the whole person. And then normalizing changes in trajectories. So doing our best to anticipate what comes next, telling the family and giving them our best guess, which can change at any moment. So with each assessment, we offer our guess of what comes next. So the spiritual and psychological needs of the dying patient. So some things to consider is definitely identifying existential distress. In a patient who's still interactive, existential distress is a pretty broad term. We throw it around a lot. It's very common in dying patients, and it's really can be thought of in different ways. Some people say it's a general hopelessness in the face of death, feeling possibly a burden to others, the loss of your dignity, yourself, a loss of meaning and purpose, all in this context of near death. Reminiscence and or therapeutic life review can be really helpful strategies in looking at this. So reminiscence is just generally considering a lot of meaningful memories in someone's life. It's common near death for families to do this. It can be a very comfortable way to be with a family if you're invited into a moment like that. Therapeutic life review feels similar in a way, but it's far more structured, and it's not only really focusing on positive accomplishments, but seeking to possibly unravel some sources of conflict and even resolve them near the end of life, helping to affirm the unique and meaningful life of somebody. When you see this done well, it can be incredibly powerful for someone who maybe feels that their life was possibly wasted at times, or they have lots of regret. When they reconsider their lives and how meaningful and interesting and important they were, and the relationships they have, that can be very, very helpful. Certainly for some people, they seek forgiveness, they seek healing of relationships and opportunities to say things to people they love and care about who they may have not talked to. Different patients may seek this out. Different family members may want to ask for forgiveness from the dying patient. So certainly important. Prayer can be important, whether the person's religious or not, may be something they find benefit from. Religious rites and blessings, again, this may be important to the patient and may be important to the family, but we definitely want to give families as much notice as possible in order to arrange for the proper spiritual figures, the proper materials, and the right people to be present to perform these adequately. For different belief systems, it's absolutely critical that these things be done at different times and with the right situation. Directly address the fears of dying. So a lot of our patients are afraid of dying. When we finally announce that you are dying and you're in the dying phase, people can be very worried and they're afraid to ask questions about it. So if you perceive that this might be an anxiety that exists, you can ask, are you afraid of dying? And they often tell you. And many patients are afraid of suffering while dying and what it's going to be like. Other patients are afraid of other things, but it's okay to directly address this with a patient who's interested and engaged. And again, this can also be of the family. They might be worried about what the dying process looks like. And then we're definitely going to aggressively treat refractory anxiety, and we'll talk about delirium as well in the physical section. So I included environmental and the social considerations. These are really shared questions between healthcare staff and families, largely driven by families and patients, but we see a huge variability between families and patients who know exactly what they want in answer to all these questions, and they have a strong feeling, they have cultural beliefs, they might have religious beliefs that support a knowledge of how to proceed with death. But then we often see families who really don't know what to do, and they are looking for guidance. So, questions that come up include, where should we be? Is this the hospital? Should we try and get to a home-like setting? Should we be, at an assisted living facility? Would that be too impersonal? Really, where should this occur? Who should be there? For some patients, they want as many people from their life as possible. For other families, that's too big, and they really want just the core people there. It's okay to have the group visitation, but truly at the moment of death, they might have a desire to just have core family or specific friends or figures there. How should we be? So can we be raucous and have a party and celebrate? Can we, do we need to be quiet and respectful? Really, these things fall back on the cultural standards, the family standards, and possibly the environmental standards of our hospital. We might have to provide some direction within reason while still trying to support what's culturally appropriate. If you perceive, again, as the healthcare provider, that some of these things might be disturbing or agitating to the patient, you might provide a little support and maybe some advice on how still to respect how the family wants to be while also minimizing the suffering of the patient. And then what if nobody is there? We struggle with this here in the hospital. We obviously would hope that everybody would have someone there at least to attend to their physical needs. But for the social and spiritual and just emotional support needs, I think there's a general sense amongst humans that we really wish that nobody would die alone. And so certainly just kind of an open question. I have no conclusions, but I know we all would hope that to be true. And then what about children? Some people are certainly afraid about children being present, being scared, being witness to such a potentially sad thing. The palliative care perspective is that with the right support, it can be really meaningful for children to see the permanence of death to witness grieving rites and rituals, which can be very helpful in bereavement and learning what it means to have someone in their family or someone they know die, and how to cope with it after the fact. And then opportunities for healing. So are there final bits of work? Are there things that the patient or the family want to do that would help bring those they care about closer together in this final phase? So then on to physical symptoms, which we'll spend a little more time on. These are some common symptoms that we see at the end of life, and we'll go through each one separately. There's certainly other symptoms as well. So fatigue and immobility, incredibly common for someone who's dying. It can be very distressing to family. They've always thought of their family member as someone who just, they need to get up, they need to try harder, they need to gain their strength back. There can be some denial in the coping of imminent death and hope that a family member will just start feeling better and get their energy back. There is something to energy conservation. For the dying patient, they may be sleeping a good portion of the day. We have a patient right now who they are awake for 30 minutes, they sleep for 45 minutes. They're awake for 30 minutes, they sleep for 45 minutes. And the family's been very supportive of that. They try and get family members in there to interact and have conversation, and then they back away when she seems tired. And there's a real respect for her limitations and trying to maximize when she does feel good, and then support her to conserve her energy for important visitors. We talk about hearing and touch being potentially maintained even when the patient is less interactive. And so that's a way to give powerless family members or family members who just don't really know, they've lost the control to help and they don't know what to do, a way to meaningfully interact with the person they care about. You know, hold their hand, talk to them quietly, peacefully, maybe read to them or say a prayer. These are all very good and helpful, soothing things. You know, thinking about someone who's bedbound in the hospital and at home, we're always worried about bed sores. We're always worried about moving them constantly. When we're truly at end of life, they might have bed sores, they might have serious ulcers, but they may also have serious pain related to their disease. And so you start to wonder what is the benefit and burden of continuing to move them. And really, truly, when you're at the end of life, there's a lot you can't prevent or treat. Decreasing oral intake. So again, another thing that Gracie has talked a lot about with us, how distressing it is for family members to see a dying patient not really feel hungry, not be interested in food. This is something we, number one, have to counsel on, normalize that this is normal for a dying patient. Their body doesn't need as much anymore. Their organs are starting to shut down. This is really hard to see, but we risk by forcing them to eat that they might actually feel worse. If their motility is not quite up to snuff, we could be causing nausea, discomfort. As their tone decreases in their mouth and throat, they might have more difficult swallowing, which could lead to further distress, even aspiration. They worry about patients being thirsty. And what's interesting about thirst and hydration is that a lot can be alleviated if there is any thirst sensation with just high-quality oral care. So focusing on cleaning the mouth, swabs, keeping the mouth wet. It's very common for the mouth to become extremely dry, and that is very uncomfortable. So oral care is very important. While the restriction of fluids can actually be helpful, possibly if someone has a lot of secretions as well. And then another consideration for someone who has decreased oral intake is to make sure you have a flexible symptom plan, particularly for patients who are at home, they are on oral medications. We want to make sure that if they can no longer take really important symptom medications, that we have another route or a way to give them these meds. And that was a picture of a subcutaneous needle, which is not something we use in the hospital, but it's something that we often see in the hospice care of patients. Next slide. So pain management, certainly something we talk a lot about. This is a picture of a common medication we like to use near end of life. It's a morphine elixir. It's highly concentrated, and that goes into the mouth. Some of it is absorbed sublingually, but a lot of it is still absorbed enterally. Even patients who can't swallow very well, they tend to do well with very, very small volumes of medications. The goal of pain management end of life, it gets confusing because opioids are the mainstay. one of our strongest they're one of our strongest pain medications, and for a lot of our patients who have complex disease, often with cancer, they do have pretty severe pain. But the goal is not to treat pain unto unconsciousness, with even family members might be confused about. Sometimes healthcare staff don't understand what comfort care really entails, but our goal is always proportional pain management. And pain management is concordant with their goals. So as we get closer to end of life, I talked about increasing sedation, sleepiness. So we talk about the trade-off between better pain control and being less alert. It's very common that the brain becomes even more sensitive to some of the side effects of opioids. And so making a good plan about, okay, it's okay if I fall asleep, but I absolutely do not want to be suffering. Well, we know where to go with our pain management. We're going to go to the point where there's no perceived suffering. If it's the opposite, well, I want to stay awake, but I want to do my best to treat my pain while still staying awake, well, then we walk that fine line with them, and we do a lot of frequent assessment. If you think about how intense that is, that means checking back every hour to really see how the patient's doing. At some point, the patient may not be interactive, and so you start to work with the family, with the friends, with the people who have been around the patient to do a shared assessment. So I'm seeing grimacing. I'm seeing, bearing down. I think they're uncomfortable. What do you guys think? Or the family may say, I think they look uncomfortable, but you as the healthcare provider might be able to provide some support. I'm not sure that is a pain response. What do you say we try repositioning and see if that helps? You can explore different strategies and do a shared assessment together, because it is really important that the patient is perceived as not suffering. And if there's some discrepancy between the healthcare provider and the family, you need to talk about it. Again, I talked about being flexible. A lot of meds can be given rectally. A lot of meds can be given in highly concentrated liquid solutions, so moving away from pills. Some patients have ports or permanent access. And then timing. When we're doing pain management in your end of life, we're no longer trying to keep a steady state. We're really looking to treat the symptom now, because we're talking about last hours of life. So if we wait hours, that's hours a patient is suffering. So we look for the peak effect. For example, a lot of oral pain medications, we might even consider assess after 30 minutes, and if we don't get a response, 45 minutes is probably more accurate to the peak effect. And then we decide, have we had enough of an effect? So it's a little more frequent, a little uncomfortable for people who would say, oh, no, morphine, I dose morphine every 3 to 4 hours because I don't want it to build up in the system. In this circumstance, we're trying to treat the symptom now. And then again, morphine is thought of almost as an end-of-life opioid because it's cheap, it's been used for so long, and it works well for a lot of patients. But no one opioid is inherently superior. We consider the patient's needs, what formulation we might want, and then limitations such as organ function that would affect which opioid we might choose. And then finally, intention is important. So I did talk about the situation where the patient says, I absolutely want aggressive pain management, even if that kind of puts me to sleep. And patients and families may wonder, okay, is the pain management at end of life hastening death? And just a reminder that the intention is what's important. There's no data to suggest that proportional pain management at end of life hastens death. But if you're not sure, what you should fall back on is knowing that you're treating with good intention to treat a refractory symptom. You're not treating to hasten death, and you're not treating to put someone to sleep. Next line. So shortness of breath, pretty common depending on the disease type. Certainly more common if there's some sort of pulmonary disease. Again, opioids are a mainstay of treatment. This is often lost on people, but opioids are thought to take away the subjective sense of shortness of breath. Nebulized opioids do work, but there's no typical role for them because it's felt that systemic opioids, so taking them by mouth or IV, are equally effective. I see more often as people fall back on the use of Ativan or benzodiazepine for anxiety, because dyspnea can be very anxiety-provoking. And while that can be helpful as a secondary medication, I want to go back to opioids and really recommending them as the mainstay of treatment. We know that passive airflow to the face can be really relieving. So just a little bedside fan, something coming by the face. If a patient is hypoxic, oxygen can be helpful. Placebo trials looking at oxygen versus air, there's no difference if people think it's oxygen. So there is some possible psychological benefit as well. And for some patients, it can be worth a trial. If you do think that hypoxia is the thing that might actually lead to ultimate death, you should discuss that if it is a pneumonia, for example, that will ultimately take this patient's life, that it could prolong any suffering that is perceived, to consider using it. And you could instead try a strategy of more aggressive opioid treatment. Non-invasive ventilation or positive pressure ventilation, BiPAP, CPAP, may actually be concordant with goals. That's a very difficult conversation. Again, like oxygen, it could actually prolong life, which may or may not be what the patient wants at that time, while it can definitely relieve shortness of breath. All the other typical medications that we use for patients who have disease-related shortness of breath could totally be appropriate. But in truly the last hours of life, I really want to focus back on opioids. We wouldn't want to wait for the effect of any of these while we're treating the symptom right now. One thing of prognostic significance is that when someone starts to have a breathing pattern with what's called mandibular respiration, it suggests that they might have less than 8 hours left to live. And to demonstrate just briefly, with inspiration, the mandible actually opens. And you may have seen it often accompanied by deep breathing. So airway secretions, I'll move quickly through this one, which is the death rattle, the sound of gurgling that occurs in nearly half of all dying patients is incredibly common. It's very distressing to caregivers and family. We do not believe that this is actually distressing to the patient, and studies have shown that it does not actually correlate with a feeling of shortness of breath. We have a lot of medications that we use to try and treat this, all anticholinergic medications, in hopes of decreasing the actual production of saliva. But in reality, we don't feel this is distressing to the patient. There isn't a lot of evidence that these medications work very well, and there's some risk that they make things so thick that it can make the patient actually uncomfortable or have even more difficulty when we suction and try and clear secretions. So positioning and counseling are really number one and number two. So often moving the patient into a more upright position, side lying, can really help move some of that saliva away from the larynx. And then careful use of oral suctioning. Notice I didn't say deep suctioning. We don't want to irritate the mucosa and actually cause increased production of saliva. Delirium and agitation, incredibly common. And really I think of it as two pathways that are kind of common. So we have someone who has this slowly decreasing level of consciousness, maybe benign disorientation, even hallucination in some patients, versus a different pathway where someone has more hyperactive symptoms. So agitation, really scary hallucinations, delusions, very concerning behaviors that are obviously distressing the patient or the family. You know, we go through our usual delirium thought process about reversible causes and toxicities, but in someone who's dying, we know that about some of these causes, you know, organ dysfunction, we're on possibly opioids. There's a variety of reasons why things that we wouldn't stop at this point would continue to cause delirium. So my recommendation, as opposed to being very conscientious about the use of medical treatment of delirium earlier in someone's course, at the end of life, we're not going to withhold treatment, specifically if we think that this delirium is going to continue unto death. So we aggressively treat this hyperactive, concerning delirium. First line has always been the neuroleptic, so things like Haldol, olanzapine, chlorpromazine for someone who's very agitated. It can be very sedating, quite helpful in that situation. Benzodiazepines we think of as potentially making delirium worse in a lot of our patients, but it's been shown in terminal delirium it can be very helpful as a second-line medication because we know we're not going to get rid of the delirium. We simply want to treat its symptoms at that point. You know, certainly there is the possible benefit from hydration, but we have to balance, again, these risks and possible prolongation of suffering. Next slide. So other symptoms, certainly if someone can't close their eyes, we want to lubricate their eyes. It's common to have incontinence, so preparing family for this, both incontinence of bowel and bladder. Seizures would be unexpected and to be new, but if someone had a neurologic condition or maybe brain mets, you could be prepared with a benzodiazepine. This could be very concerning to someone who had a terminal seizure. Fever infection, again, falling back on those goals of care. But fever is uncomfortable, and you can try antipyretics if you want. Antibiotics would not really be expected to be helpful in the last hours of life. Someone is dying still, and I wouldn't recommend them. Palliative sedation is its own conversation, but I did want to recognize that for someone that has truly refractory symptoms, has been assessed, and the usual course of treatment has been tried, certainly can be a discussion that sedation might be the tool we want to look at to alleviate the suffering. So in summary, really end-of-life care is not only care for the patient, it's the care for family, caregivers, and friends as well. We didn't talk about the care for the body because I think that's its own conversation, but coming up with a good plan with family, what are we going to do afterwards, knowing a little bit about what you're going to do for the family in that situation. And then care for ourselves, so being there for each other, supporting each other, particularly people who are first time supporting a family or patient through end of life. Super helpful to have someone to reassure us. Next slide. This is an Isaac Asimov quote. Someone spelled his name wrong, which makes a you-know-what of me. But I think this is just such a universal struggle, and I get asked daily about advice on situations like this. And so I know we've run out of time, and I apologize for that, but it's a little bit too big of a topic, I think, for 25 minutes.
Well, I just want to thank Sean for sharing this important talk. We do have a few minutes for questions or thoughts. Does anyone have any questions or comments? Maybe we'll start off with the phones first. Just know it might take a second for phones if you have something to ask. All right, we're going to go out. Does anyone have any questions out that are on camera? You can wave your hand, or you can use the chat function to ask questions as well. And then I was just going to ask what's that? Oh, Stacy has something, so. We're going to go to ANTHC Conference Room 1.
Yeah, I just a question about, you talked about like the facial changes, and I guess I've had experience with several family members that before they passed away, their face actually changed, and their resting face was either open or their jaws were contorted. And so I guess from what you're saying is that is part of the dying process?
It's very common. Not all patients look like that, but if I walked into a room and I saw a patient like that, I would actually think they're very near to death. The thought is that there is a relaxation in a lot of the muscles in the face and the neck. And it's not completely understood exactly why sort of that breathing with the bottom part of the jaw opening up occurs. But it's definitely a prognostic sign that there's and it can occur in other situations that are not death, but in someone you know is near death, you would say, I think they're really close to the end of life. So it can be pretty common. Now, if there was gritting or bearing down, I might think about treating the gritting of the teeth with something to relax those muscles, but in a relaxed state, I'm not too concerned about that.
Yeah, it's interesting. I wish somebody would have said that, you know, educated the family a little bit. We're just kind of left wondering.
Yeah, I think unfortunately there's a role confusion too about who should be the one to announce certain things like this. In the hospice setting, hospice nurses are liberated in order to provide their assessment and their thinking about things, but in the hospital, sometimes nurses don't feel like it's their role to step up and provide that without the support of a provider. They also may be so used to it that they forget that each of these things would be so new and so dramatic to a family as to think to explain them. So all the more reason for more education, more support, and talking about these types of cases and the importance of true end-of-life care, like the last hours of life, how much work there is to be done, particularly in family counseling.
And Stacy, I just want to say thank you so much for sharing that personal experience. It was really helpful to hear that. And as a reminder for all healthcare providers, our role in counseling and helping people in those last moments. So, well, I was just going to say, again, I just want to thank Sean for sharing this really important topic. Again, we could talk another hour about all these issues. There's so many complexities to it. If you have questions too, feel free to reach out to our palliative care team at 907-729-1112, and we can get you connected to one of our team members to help answer those questions.